Hello, my name is Alison Moran, and I am going to tell you about starting my addict to state therapy after acute coronary syndrome. Definition: acute coronary syndrome is a condition caused by a sudden reduction or blockage of the blood supply to the heart. Acute coronary syndrome is usually caused by the rupture of plaque or the formation of clots in the arteries of the heart. Symptoms might include heart attack like chest thickness when resting or joint-like activities, or sudden cardiac arrest. People can suffer pain areas, chest, arms, or jaw. Circumstances in which pain occurs in the chest at rest or when exerting. Respiratory shortness of breath or shortness of breath when exerting. Also common chest thickness or shredding.
Acute coronary syndrome, ACS, is a group of conditions that occur when blood supply to an area of the heart muscle, the myocardium, is suddenly reduced or blocked. Reduced blood supply is termed ischemia. A prolonged ischemia can lead to death of the heart tissue, known as heart attack or myocardial infarction. A typical symptom of ACS is central chest pain or discomfort that may spread to the back, jaw, left shoulder, or arm. The pain may also be felt in the abdomen and can be mistaken for indigestion. Other symptoms include shortness of breath, heavy sweating, nausea, palpitations, and fainting. Women and older people often have atypical symptoms. Chest pain is not reported in about 30% of cases. About 20% of patients have mild or no symptoms. Risk factors include aging, family history of heart diseases, smoking, diabetes, hypertension, high cholesterol, obesity, sedentary lifestyle, unhealthy diets, and psychosocial stress. The most common cause of ACS is the formation of a blood clot in an artery already narrowed by an atherosclerotic plaque. Plaques are deposits of lipids, fibrous tissue, and calcium that accumulate slowly over time. A plaque may become inflamed and rupture, exposing substances that promote coagulation, producing a blood clot on top of the plaque. Less common causes include coronary artery embolism, coronary spasms, and coronary artery dissection. Depending on the location and the extent of obstruction, one of the following conditions may result: unstable angina, non-ST segment elevation myocardial infarction, non-STEMI, or ST segment elevation myocardial infarction, STEMI. These conditions are differentiated based on ECG findings and cardiac marker levels. Markers are substances released into the bloodstream upon death of cardiac myocytes. Cardiac troponins are the markers of choice as they become elevated early in the disease process. The amount of troponin released is proportional to the infarct size. Most patients with infarction show elevated troponin levels within 6 hours. Troponin assay is usually done on presentation and then repeated a few hours later.
Application in medicine. Ezetimibe addict to stem production additional LDL cholesterol reduction of up to the 20%. Given that the reduction in LDL cholesterol is associated with a decrease in the risk of developing cardiovascular complications. It is logical that this additional reduction in LDL cholesterol obtained with ezetimibe would translate into a reduction in cardiovascular events. Ezetimibe is a new oral cholesterol-lowering drug which has been approved in the last years. It belongs to a new class of sleeping lowering drugs, signs It has a different mechanism of action inhibiting the absorption of cholesterol from the intestine.
Hi, I'm Dr. Nathan Ritter from cardiogauge.com. This video is about ezetimibe, used to be known as Zetia. Stay tuned to the end when I'm going to talk about how I use this medication in my practice. It's been around since 2002. It decreases LDL cholesterol by inhibiting the absorption of cholesterol in the intestines, so it works totally different from statin medications. Its dosing ranges from 5 milligrams per day to 10 milligrams per day, and frankly, I don't think I've ever used the 5 milligram dosage. I would just use 10 milligrams. Side effects: constipation, bloating, a little diarrhea. Would rarely cause muscle aches. Maybe 1 in 50 people might get that, so way less common than muscle aches with statins. And overall, it's a well-tolerated medicine. It doesn't really require lab monitoring, although patients are often on statins and they're getting their liver and kidneys checked, that type of thing. The proof on this medicine isn't the greatest. There's a trial when it was used with simvastatin, and it did decrease the chance of death a little bit over a 6-year period. That's in people who had a coronary blockage, but it hasn't been well tested with atorvastatin or rosuvastatin, which are more commonly used cholesterol medicines and more potent at decreasing the LDL cholesterol. So I wouldn't consider it the best studied medication. So how do I use it? I'll use it most often in people who are intolerant of statins. Maybe they had a heart attack or stroke, and they tried atorvastatin, they tried rosuvastatin, pravastatin. All of these cause muscle aches or some other problem. So then we need some other means to decrease the LDL cholesterol, and I'll try ezetimibe. The thing is, it's not well proven to decrease chance of stroke, heart attack, or death in those patients, and rather we're just treating the LDL cholesterol, so it's not an ideal treatment. And frankly, in patients who are intolerant of statins, it becomes more important for them to eat right, eat a whole food plant-based diet, which if you pitted whole food plant-based diet versus ezetimibe, the whole food plant-based diet would crush it. I also use ezetimibe in people who have high LDL cholesterols in spite of maximum doses of atorvastatin or rosuvastatin. So say somebody had a heart attack, now they're on 80 milligrams of atorvastatin per day, and the LDL cholesterol goes from 220 to 100. We really want the LDL cholesterol lower than that, so we try diet and exercise. Obviously, those are better choices for reducing LDL cholesterol than another medication, but if that doesn't work out and the LDL is still 100 or so, then I will add ezetimibe on top of that to get the LDL to more like 80 or something. Another use for ezetimibe would be in somebody who hasn't had a stroke or heart attack, but they're at high risk of this occurring. The typical case would be somebody with a family history of coronary blockage. Say their mother had a heart attack at age 50, brother had a heart attack at age 55. So this person is at quite high risk, and their LDL cholesterol isn't low enough with maximum dose of statin. The LDL is 100 or 120 or something like that. I would add ezetimibe to that regimen. Lastly, I'll use it in people who are statin intolerant and at high risk for heart attack or stroke. And that could be a person who's already had a heart attack or stroke, or somebody who has a lot of risk factors, diabetes, high blood pressure, family history, and doesn't tolerate a statin. I will occasionally use ezetimibe alone. Bottom line, though, is it's not the best tested medication, and it would be better if someone could lower their LDL cholesterol by eating a healthy diet, which the best diet appears to be a whole food plant-based diet. I would consider that preferable to ezetimibe. Thanks for watching. Hit like and subscribe. It helps get the feedback. And if you have any questions, leave them below. I'll try to answer them.
Clinical indication. Ezetimibe might be beneficial in combination with statins for those patients who do not meet the therapeutic objective with usual dose as statin and who do not tolerate high dose as these drugs. It can also be useful in patients who cannot tolerate even low dose of statin, being especially indicated in patients with hypercholesterolemia with homozygote familial variety, in one the usually agent has limited efficacy. In the absence of clinical and safety results in studies with a longer follow-up, experiments show the reservoir for patients who do not reach an adequate level of lipids in the blood with the maximum tolerated dose of statin. Cons: headache, paresthesia, dreaming, gastritis, back pain, muscular weakness, pain in the extremities.
Treatment with statins reduces LDL cholesterol and lowers the risk of cardiovascular events. The IMPROVE-IT trial was designed to see whether the addition of ezetimibe, a drug that decreases intestinal cholesterol absorption, reduces cardiovascular events even more. 18,000 patients hospitalized after an acute coronary syndrome were included in the trial. Participants were randomized to either simvastatin plus ezetimibe or to simvastatin plus placebo. At the start of the trial, mean LDL levels in both groups were 94 milligrams per deciliter. During the study, the median time-weighted average LDL was 70 in the simvastatin placebo group and 53 in the simvastatin ezetimibe arm. The primary efficacy endpoint was the time to death from cardiovascular disease, major coronary event, or non-fatal stroke. At 7 years, Kaplan-Meier event rates for the primary endpoint were 32.7% for simvastatin plus ezetimibe and 34.7% for simvastatin plus placebo, a statistically significant 2% absolute risk reduction. Approximately 50 people would need to be treated for 7 years to prevent one event. No differences were observed in cardiovascular or all-cause mortality, and there were no significant differences in the pre-specified safety endpoints. In this trial, then, ezetimibe provided incremental LDL lowering when added to statin therapy and modestly improved cardiovascular outcomes. Full trial results are available at nejm.org.
Use applied in Ecuador. In Ecuador, it is estimated that mortality from cardiovascular causes in people from 30 to 69 years is 20% in men and 21% in women. The year 2021, the therapies, the type of system, the dose used, and the combination with other drugs do not form part of the statistical protocols, and it is like that very big setting and clinical experience. The addition of ezetimibe to simvastatin 14 milligrams after an acute coronary syndrome in patients with not very high baseline LDL cholesterol produces additional benefits in terms of the reduction of cardiovascular events, without an increase in the incidence of adverse effects. The country does not have established protocols or standards of care for acute coronary syndrome in the first and second levels of health, despite having high mortality figures due to pathology. Thank you.